Hi, my name is Brittany Kelso. I'm a student here at USF, and this is my clinical experience case study. I conducted my capstone on a labor and delivery unit. And so my patient was a 20-year-old female. She was a Gravida 1 Para 0. She was 39 weeks and 5 days gestation. She was unmarried, but living with the father of the baby, and both were employed. For past medical history, she did have COVID prior to pregnancy, which she was off of work for 3 months for, and it also caused her to have intermittent visual floaters. She also has a history of migraines. She was anemic at 35 weeks. Her red blood cells were 3.39, her hemoglobin was 9.8, and her hematocrit was 29.1, and this was successfully treated with ferritin. She doesn't have any current use of drugs, alcohol, or smoking. At 36 weeks, they did find an umbilical vein varix of 9 to 10 millimeters, and this is just a focal dilation of the umbilical cord. And so after this, she was prescribed 2 times per week antenatal testing to just monitor the baby. As far as family history goes, there's a history of blood clots, and her father has ankylosing spondylitis. Her current med use includes a prenatal vitamin, ondansetron for nausea during pregnancy, and promethazine for her migraines. All right, so for nursing assessment, her primary diagnosis was an induction because earlier that day they could no longer visualize that umbilical vein varix, and so they thought it best to proceed with just delivering the baby. When she got to us, her physical assessment, she was 1 centimeter dilated, 50% effaced. She had no reports of headaches, right upper quadrant pain, vision changes, or edema, so nothing consistent with preeclampsia. And she did not report any bleeding or rupture of membranes. She did report feeling contractions throughout that day and currently when she came to us. Her fetal heart rate tracing showed moderate variability. The baby's heart rate was 125 beats per minute. There was acceleration, so overall it was reactive. As far as her contraction pattern goes, they were every 2 to 4 minutes with 50 to 80 seconds in duration of mild strength, and there was a soft, the resting tone was soft in between contractions. Her vital signs, so her temperature was 97.4 degrees Fahrenheit. Her heart rate was 100 beats per minute. Her respiratory rate was 16 breaths per minute. Her blood pressure was 130/80. That was a little high, but she was nervous when she came in. And then her oxygen was 100% on room air. So as far as medications goes of what we gave her while she was in our care, we gave her a one-time dose of fentanyl, IV fentanyl for pain management. She also got an epidural for pain management later on in her stay. We also gave her ondansetron for nausea, and then following her epidural, her blood pressure did drop, so we gave her phenylephrine. Okay, and then some diagnostic tests. So on admission, we did a type-in screen, which showed she was AB positive. So this just means that she does not need a RhoGAM shot following a birth. Her rubella and varicella were both non-reactive. So this just means that either she was not immunized in the past for these, or the immunization, her immunity waned. And so we will offer her these vaccinations postpartum if she would like them. And then as far as Hep C, HIV, and syphilis, these were also non-reactive. So she either didn't have a past infection with them, or she wasn't currently infected with them. Same goes for her Group B strep. This was negative as well, so she didn't have an active infection of this, and so she did not need antibiotics during her labor. Her red blood cells, hemoglobin, and hematocrit were all low again, so she was anemic. Earlier in the day, at her prenatal appointment, she did have a biophysical profile and an ultrasound done. So the biophysical profile showed the score was 8 out of 8, so the fetal well-being was was good. And the ultrasound just showed that, it was a single baby. The baby was head down or cephalic. The placenta was anterior, and the amniotic fluid index was within normal limits. So everything looked good with that. So for nursing diagnoses, one of the main ones was labor pain related to onset of active labor, as evidenced by patient needing to breathe through contractions and patient reports of increased discomfort. The second nursing diagnosis was risk for decreased cardiac output related to low blood pressure following initiation of the patient-controlled epidural analgesia. And lastly, risk for impaired parenting related to young parental age. So the patient's care was planned to address priority needs by assessment of both the maternal and fetal well-being. For example, we treated the patient's blood pressure when it dropped after her epidural placement, and that took priority over other interventions like helping her to void or ambulate. So our goals for labor pain was that the patient will participate in decision-making regarding pain management interventions throughout labor, and then the patient will report pain as manageable throughout labor. And for risk for decreased cardiac output, the goal was the patient's blood pressure will remain within defined limits, and the fetal heart rate tracing will remain a Category 1. And then for risk for impaired parenting, our goal was the patient will identify strengths, weaknesses, resources, and needs for parenting by discharge, and the patient will demonstrate appropriate attachment and parenting behaviors towards the infant by discharge. So implementation. So for labor pain, some of the interventions we implemented, we began with non-pharmacologic. So we gave her a birth ball that she could sit on. We also gave her a peanut ball that she can lay in bed with. She did ambulate both in her room and out in the hallway, and she had a warm bath earlier on in labor. And then we progressed to pharmacologic interventions. So she did get that 1 dose of IV fentanyl, and then later on, she got a patient-controlled epidural. For risk for decreased cardiac output or interventions, prior to the epidural, we did bolus her with half a liter of lactated Ringer's, but after her blood pressure dropped following the epidural placement, we did bolus her again with the other half liter, and then she did get 3 doses of phenylephrine. And then for risk for impaired parenting, our interventions, we assess the patient for strengths, weaknesses, resources, and needs related to parenting. Specifically, talk with the patient about where she and the father of the baby works, whether she was able to have maternity leave, who was going to watch the baby once she returned to work, and just the available support systems she had in place. We also encouraged participation from both the father of the baby and the patient's mother in the birth process. As far as health promotion and disease prevention went, we of course repositioned her following her epidural placement, and kept her dry and clean. And then we straight catheterized her following the epidural to just make sure the bladder didn't become distended. For cultural considerations, since she was a younger parent, we encouraged the father of the baby and the mother of the patient to participate in supporting the patient as much as possible during labor. As far as coordination of care concerns goes, we updated the obstetrician about the patient's status and progression through labor throughout the shift. And we also updated the anesthesiologist that the patient's blood pressure did not improve following those 3 doses of phenylephrine. So evaluation. For labor pain, the non-pharmacologic interventions were effective in the short term, but they eventually became ineffective as labor progressed and the patient's pain increased. The dose of fentanyl was also only effective in the short term and helped manage the patient's contraction pain for about an hour. And then eventually we got her that epidural, which was effective in the long term to help manage her pain. Overall, I would not change her interventions. We educated the patient on pain management options and proceeded from least to most invasive and eventually achieved our desired outcome of adequate pain management for her. For risk for decreased cardiac output, the bolus of lactated Ringer's and 3 doses of phenylephrine were effective in the short term to bring the patient's blood pressure back within defined limits. However, after that last dose of phenylephrine, her blood pressure did drop again to 84/38. And so after that last dose, we contacted the anesthesiologist, who then provided an order for ephedrine if the patient's systolic would drop below 90 again. This all occurred around shift change. So after we had got that order for ephedrine, we had already transferred the care to the day shift nurse, and so we did not administer any ephedrine when she was under our care. The fetal heart rate tracing did remain a Category 1, so even though the patient's blood pressure did drop a few times, the baby's well-being was not affected. Overall, I would not change our interventions. We followed the standing orders for low blood pressure following epidural placement, and then when those failed, we contacted the anesthesiologist for how to proceed. For risk for impaired parenting, so assessing the patient through casual conversation during her stay allowed us to gain sufficient knowledge about what resources she had to help with parenting. However, as the patient had yet to give birth during our shift, I was unable to assess if she demonstrated appropriate attachment and parenting behaviors towards the infant. Overall, though, I would not change our interventions. We were able to assess the patient adequately for resources and support systems, both of which she seemed to have in place. And that concludes my PowerPoint presentation. Thank you.